delighted to invite you all to our seminar where we're welcoming Dr. Nwosu, who's a clinical lecturer in palliative medicine. Is that right?
That's
yes.
Correct, yes.
But also, I'm just going to say, but not for very much longer. You can tell us about your plans. And he's going to talk to us today about his work on hydration status, but also, I think, talking a little bit methodologically as well about some of the issues of advanced consent, which will be of interest, I think, to all of us. So thank you very much for joining us, Ami, and apologies for our technical delays, but off you go. Thank you.
Thank you very much. As I said, my name is Nwosu. I'm a clinical lecturer in palliative medicine based at the University of Liverpool. It's a real honour to come here today to present to you some of my current research, which is assessing hydration status, symptoms and quality of life in advanced cancer at the end of life. So some overarching aims that I have for today is to discuss my research about using a non-invasive assessment tool to assess hydration called bioimpedance. I also want to discuss potential other applications of bioimpedance in palliative care. And thirdly, I'd like to discuss the potential opportunities for future collaboration with teams here in Lancaster. First of all, I wanted to tell you about why I'm here, how I became to be a doctor, and how I came to be a researcher. I'm from an immigrant family. I was born in Nigeria. When I was a year old, we emigrated to the UK. My father is an obstetrician. My mum is a nurse. My dad at the time wanted to come to the UK to learn skills and to go back to Nigeria, like many doctors working in Commonwealth countries wanted to do. He came across in 1982 after I had just been born, and there was just me and my mum at home in Nigeria. I wasn't very well, baby, and I was struggling to put on weight, and my mum took me to see a pediatrician, and the pediatrician, who did a very holistic assessment, said, my diagnosis is that he misses his dad. So my mum got on a plane and flew into Edinburgh with just me and a small suitcase, and she thought, it's a bit cold here. And then we ended up staying there for a while, moved to Glasgow. My brother was born in Edinburgh. And then we went to Middlesbrough for a period of time, Sunderland for 5 years, Newcastle, and then we moved down to Liverpool after my father was appointed as a consultant in Wiston Hospital, which is in Liverpool. Now, we didn't have any family in the UK, and my mum's sister, my aunt, is the lady that's in the middle of the screen here. She would come across at short notice, just crazy. She'd fly across to help my mum out for a few days and then fly all the way back to Nigeria. So I love my aunt with all my heart. She was one of the real important people in my life. When I was doing my A levels, she was diagnosed with metastatic breast cancer, which was just awful. She came to live with us, and one of the things that you see in traditional African families is the eldest son or the eldest daughter who does a lot of the work. So I was getting the sofa bed ready for my mum in the evening, for my aunt in the evening. I then help get up, make her breakfast. We'd go to all the clinical appointments that she had with the oncologists. We helped her do the BBC News interview where she was trying to get dispensation to allow her sons, so my cousins and her husband, to come across to Nigeria to stay. And then she deteriorated. She had metastases. I didn't really understand what was going on, even though I classed myself as an NHS child, because growing up in doctor's accommodation in Edinburgh, Glasgow and Middlesbrough, I thought it was normal for all of your pillows to have NHS branded on them and for there to be a sink in every room. I remember going to somebody's house going, where's your sink? Where's your sink? So even though I'd spent, I'd go to school, and then my parents would take me in to be babysat at the nurse's station whilst my dad had to go and see somebody on call, and I'd be there for hours waiting for them to come back. So I was used to hospitals. And I would go around all these different hospitals, and was admitted to the Royal Liverpool Hospital with what I now know to be as hypercalcemia, a high calcium. And I saw her weight fall off, and then she was transferred to Marie Curie Hospice in Liverpool. Up to this point, I said I really didn't want to be a doctor because I had many Christmases and bank holidays and summers where I was being passed around different babysitters because my parents had to work. So I actually wanted to do arts. So my aunt was admitted to Marie Curie Hospice. She was dying. My cousins were there in tears. The priest was there. She had a really loud noise, which I now know is respiratory tract secretions, but I didn't know that at the time. Nobody told me what that was. And she died. And it felt like everything had finished. It was just awful. And a healthcare assistant put her arm around me and said, "This must be really difficult for you." And that was the first time, really, that for all the contacts that I had with the health service, every other people had been nice. They hadn't really talked to me as a significant person in this. I was always a young person, and they would have the discussions with the adults. So that was such a powerful moment, and it really made me kind of look around and said, well, why is there a doctor here? Because it's a hospice. I thought it's a place for you to die. So that really changed my perception of what healthcare was, what it could mean to be caring, and what palliative care could be. My aunt received excellent care. It's because of the experience of a kind healthcare assistant who still is working in the hospice today, that's what chose me to be a doctor, but also a researcher. Even though my aunt had excellent care, there's unanswered questions I have. Could young people, like myself, my cousins, and my brother and my sister, could have been supported better? The specific challenges that you have for immigrants or ethnically diverse people, because trying to communicate back to our family in Nigeria why my aunt had died and that she died in the hospice when they didn't know what a hospice was and didn't recognize palliative care was a challenge. How can we best manage patients with hypercalcemia? Because I went from being told she needs fluids because there's a problem with her blood to then seeing that there was no fluids at all because she then had secretions, but that wasn't communicated with me. All these questions, and I realized that when I became a doctor and I was looking for a specialty, that I was drawn to palliative care, but I was drawn to research, and I wanted to answer some of these questions that was posed by my aunt. So one of the things that I grasped with the opportunity when I had the opportunity to do a PhD was to try to answer one of these questions. So that's why I looked at hydration. So hydration in cancer is important because all intake decreases with advanced illness. And we have a lack of hydration assessment tools in advanced disease with limited evidence about the benefits of clinical assisted hydration, which can be extremely distressing for patients and relatives. And it's a research priority in palliative and end-of-life care. There's been 2 Cochrane reviews in 2008 and 2014, which say what Cochrane reviews say, that there's not enough evidence. And we've had the James Lind Priority Setting Partnership, which works with the public to set their research priorities. And from this document, there were 3 priorities for hydration. Broadly, it's what are the benefits of giving artificial assisted hydration? Is it necessary to ever withdraw food and drink? And if somebody's getting fluids, when should you stop? That's basically it in summary. And then there's guidance in the BMA, which talks about needing to assess individuals' needs for hydration and the benefits, but they don't really tell you how to evaluate those needs or what the benefits of hydration may be. And if you think that it's in their best interest to have hydration, then you must give it. But then if you think that it's not in the best interest, then you should stop. But it's useful, but it isn't really, because it doesn't really tell you what the evidence is or how to assess hydration or what the needs are or what the benefits are. So this is what I'm left with. Does anybody know what this is? Gordian knot. So the Gordian knot comes from the town called Gordian, which in the 4th century is famous because of Alexander the Great. So Alexander the Great in 3030 BC on his quest to conquer the whole of the known world. He was only 23, and he'd already conquered, a great part of the popularized world, right into Gordium, which is in Asia Minor, which is modern-day Turkey, I think. And he sees this ox cart, which is tied by a big knot, just a ridiculously complicated knot. So Alexander the Great goes, well, what's this knot about? What's going on? And they said, oh, this knot's been there for 100 years. And the story is, the prophecy is that whoever can untangle the knot is going to go on to conquer the whole of Asia. So Alexander the Great, a bit like my son at the minute with his football tickets collections, going, oh, I want it all. That sounds good to me. And so he tries to untangle the knot. So there's a group of people watching Alexander the Great struggling to try to untangle this knot. The story is he gets frustrated, steps back, pulls out his sword and says, it doesn't matter how I loosen this knot, and just slices it in half and then gleefully holds both sides of this knot. So the story of the Gordian knot has now become popularized as a way to see a complex problem and to try to think outside the box. So for me, for hydration, the complex problem was, how can we assess the needs and benefits of hydration when there's no evidence about this? And the solution, rather than coming in with a sword, even though that might be normal behavior for some people in Liverpool, is can we have a little look about what the relationship between hydration and physical signs and symptoms is first? Because for me, what I recognized is a lot of the studies about hydration to date were coming up with different ways to assess clinical hydration in the first place. Some people were using what a clinician saw. Other people, it was their blood pressure or their biochemistry. And the evidence is, the biochemistry often it may not be appropriate in people with advanced cancer and those approaching the end of life. So they were using different ways to classify hydration. And then they were using different outcomes. So there's a big BIOELECTRICAL study which looked at a randomized control trial giving people hydration, and he used the Edmonton symptom scale and basically found that there wasn't any benefit, but there was no prior work to establish whether or not hydration affected any of those symptoms anyway. So we've got a lack of outcomes and objective ways to assess hydration. So that's what I tried to come at. Could I try to improve the way that we assess hydration, and can we use this to demonstrate a relationship between hydration states and symptoms? So there's a non-invasive assessment method called bioelectrical impedance analysis. Bio means living, electrical is electricity, and impedance means about resistance. So it works on the principle that electrical current flowing around the body will meet different structures and encounter different amounts of resistance depending on what it's passing through. So fat, muscle, and water will provide different levels of resistance for this electrical current going around, meaning that if you apply this to a person, that you can get some idea of their body composition. So examples are what we see at the bottom of the screen, like home weighing scales. People who go to the gym may have been on treadmills where you have to grasp a little metal bar, and it kind of gives you a readout of your metabolism and your fat mass and things. And then you've got the more high-end equipment that you see at the right of the screen, which has been used in sports medicine and renal medicine for the past decade or so. It's non-invasive, so it's completely painless. It takes a few seconds. It can be done at the bedside. There's not been any reported evidence of any side effects. It's been validated against gold standard reference methods like underwater weighting, MRI scanning, isotope scans. And it correlates extremely well with total body water. So R is 0.9 and the perfect relationship is 1. So the problem that you have is that if I did an assessment on you here in the audience or you watching outside, is that in order to accurately predict things like where your water is, whether it's in your cell, outside your cell, I'd need to use a regression equation and put in variables like your weight, your height, your gender. And the problems that you have with advanced cancer is that the assumptions that you have with those equations may not be met with advanced cancer patients, so because they might be at the extremes of physiological parameters. So a way you can get around this is by using something called a vector analysis. Bioimpedance bioelectrical impedance vector analysis, or BIVA, which is the term, which allows you to do a graphical analysis, which doesn't rely on these regression equations, meaning that we can use them in advanced cancer. So I'll tell you a little bit more about that, just to set the scene. So here I am in 2012, after I just managed to get small amounts of money to do my PhD, and this was the first day that I was able to start assessments after getting ethical approval for the original study. And you can see in the background there's a dehydrated plant. All right. So bioelectrical impedance analysis. So this is what it looks like. You've got a lady lying down who's got electrodes on her hand and on her foot. It works on the principle that water, 14% of your water is in your fat mass and the majority is in your lean muscle. And if you put this electrical current going around your body, you're able to measure the resistance, and then it will be detected at the other electrode. So it takes about 2 seconds once you press the button to get the result. Okay. So now, bioelectrical impedance vector analysis, BIVA. There's a picture of a BIVA, and effectively, it's a graphical way of viewing it. It's a bit similar to an ECG. Anybody that's seen an ECG, or another word for it as a heart trace, is that you're seeing a little kind of graphical image on a piece of tracing paper, but behind it, it's quite complex mathematics and physics, which you don't need to know about. But if you can interpret these peaks, then you can understand what's going on. That's a bit similar of the BIVA method of how you can interpret this bioimpedance data. What it does is that it takes population level data. So studies which have used bioimpedance on 100 or 1,000 odd patients, so that you've got a population. So imagine that we've taken the population of the whole of Lancaster, and the previous studies done those bioimpedance assessments. So then we'll be able to develop a normal distribution. So if you look at this, imagine this is a normal distribution coming out towards you in the theatre, where the 50%, where in the middle, you've got the 50% confidence interval. That's the top of your bell curve, right? So what you've got here is 50% of the population, 50th percentile, confidence interval, then the 75th percentile and the 95th percentile. So what you've got here is what your population looks like. Now, in the middle, that's basically normal. And then at either poles, you get into the extremes of that population. So the further north you go, the more dehydrated people are getting, because they've got less fluids. The further south you go, people are becoming more edematous. The further kind of east you go, people are getting less muscle mass, they're becoming more cachectic. And the further kind of west you go, people are getting more bulky. This is your reference population. So then when you do individual assessments or group assessments, you can overlay it on this, so you can see how your patients compare to the population or how they compare to each other. So the usefulness of bioimpedance vector analysis means that you can do these assessments without the limitations of the regression equations, and it allows you to do those comparative assessments, but you just can't get those fine data about exactly how much intracellular water that person has. So this is what we use for the original study. It also means that you can divide up this graph where if people are within the 50th percentile, you can say that they're normally hydrated. If they're at the top, they're less hydrated. If they're south, they're more hydrated. So this means that you can do 4 different types of analysis. So I could do individual assessments of everybody here. So Amy, I could do assessments on you, and then I could plot you here and work out whether you're normally hydrated, less hydrated, or more hydrated compared to our reference population. I could also do the same assessment in a person over time. So I could see how your hydration changes after hydrating you, or if you've had cholera, how things change, whatever. That's not necessarily about you, Amy. That was my lecture. Yeah. So for example, here on the right, you can see this is data that's taken from somebody that's receiving dialysis. So they start in the more in the edematous portion. They've been on the dialysis for a few hours. They've had several assessments, and you can see how the longer that they're on dialysis, it's being picked up by their bioimpedance. So that's another way that you can use this technology. You can do group comparisons, so you can compare. You can do a series of assessments, take the mean of that group, and then compare it to the mean of another group. So I could take all the people on the left side of this lecture theatre, do a mean a sample on you, and then see how the different sides compare to each other. And what you see on the left is a study where they compared people who don't have cancer to people who do have cancer. And all you need to know is that, these ellipses account to the confidence interval that there's a significant difference between the control group and the cancer group. It just shows you that there's a difference there. And then the last thing you can do is that you can standardize all of the populations on a graph. So I could do everybody's assessment here, come up with the mean factor for the whole population, standardize it by Z-score, a bit similar to what you do for DEXA scans, and then compare that to other populations or diseases. So what you see on the right here are the studies with cancer, HIV, and anorexia clustering around that cachectic quadrant. The studies which looking at obese and edematous and renal failure and dialysis patients clustering around the more edematous bit. Studies looking at climbers and athletes being in the more muscular bit, and studies which have looked at cholera being in the top right bit. So a simple assessment gives you quite a lot of information depending on how you want to use it. So the original study was to use the BIVA method to see the relationship between symptoms, physical signs, biochemical measures, and survival. It was an observational study done as part of my PhD over a 10-month period, Marie Curie Hospice, Liverpool, and we recruited 90 patients. And we did a variety of assessments, looking at hydration through the BIVA method, patient symptoms, physical signs, biochemistry, performance status, medications. And our findings were that we had a recruitment rate of 77%. People really want to be part of the study. And 11% of patients were less hydrated, 48% normally hydrated, and 41% were more hydrated, which was a bit surprising to us because looking at this objective way to assess hydration, it looked like people had more water on board than we expected. When we looked at people who were less hydrated, we used a different way of assessing total body water. So we were able to do different ways to look at this survival analysis. But what we found was that lower hydration levels were associated with increased symptom intensity. So this was through regression analysis, increased physical signs, and short survival. So, and median survival in our group was 62 days, so about 2 months. And we only had 4 patients in the last 7 days of life. So what's important to say is that this study effectively is the first study in the literature to use an objective method of assessing hydration, and was the first to show these associations with signs and symptoms of hydration. And it suggests that there is an association between hydration and these physical signs. So, but what this study is not saying is that we need to be giving patients artificial hydration because it's an observational study, so it can't prove causation. What we are seeing is an association, but we can't say that people being less hydrated is what causes them to have more symptoms. It could be that it's a way of picking up some of the most sicker patients. It could be that people who've got more active disease have got more symptoms and might be less hydrated. But for us, it was an interesting finding which needed further exploration. What was also evident was that we only were able to recruit 4 patients in the last 7 days of life, just because patients approaching the last week of life were difficult to recruit, which is what led us to want to develop a study where we could find a methodological way to recruit these patients. The other thing to mention was that our median survival was 62 days, so the bioimpedance was able to tell quite early on, the prognosis of these individuals. So there is the potential that, we could try to look at interventions to improve people's quality of life at that stage 2 months before they die. So these are the graphs which have been published in PLOS One. So you can see how I've used the method to separate that out, and the clustering that you have on the bottom. And then there's our Kaplan-Meier chart with people who are in that less hydrated group, and you see the dotted line that they have worse survival compared to the others. So this was a little poster that I designed for our nurses, just so they could understand the study that they've been part of. Just showing my study showed lower levels of hydration were associated with increased physical signs, increased symptom intensity, and short survival in advanced cancer. So the outcomes were that we've had a few publications from this. we were quite keen to promote that patients want to be part of research with a recruitment rate of 77%. And then the main study was published in PLOS ONE. And I won third place for the Early Career Research Awards from the EAPC. I've won the National Cancer Research Institute Conference Prize on 2 occasions for the prelim work and then the final work. And then I also won the APM Twycross Prize. So that is me getting the rewards from Jason Boland. And the biggest accolade before today was being invited to present this in Hull by Amy when she was a clinical lecturer there. Okay, so the answer questions coming out of this work were: how does hydration relate to symptom burden in the last 7 days of life? How is hydration associated with quality of life? How about respiratory symptoms and myoclonus? What's that association? And what are the views of, people important to patients like families? Those are the things that we couldn't answer. So I had some discussions with some patients, and it was quite difficult to access to the official PPE team, so I just did it myself. So I found 2 volunteers who had both had bereavements of people who had hydration issues, and they told me that what they really wanted was quality of life studies, more awareness for patients and their families, and a way to look at what's most important for people the last 7 days of life. So that's kind of what matched up with the outcomes. And I also had interviews with a patient in my Puri Day unit who was meant to be coming with me to the ethics meeting, but unfortunately she became ill, but we had that all set up. So then the current study was basically the next step. In a nutshell, what we wanted to do was to look at quality of life, to find a way to do end-of-life care assessments, and to find what patients and their family thought. So this is the current study that we're currently recruiting to. And why are we doing this? Well, we think if we can understand better which signs and symptoms are linked to hydration, we could have some standard outcomes. We maybe develop a clinical hydration assessment tool, which could then be used for further intervention studies to standardize outcomes, but could also be used on a clinical basis when people are doing their individualized plan of care for patients to see, well, previous studies demonstrated that fatigue and dry mouth and thirst may be important indicators. Should we give you 24 hours of fluids to see whether this works or not? So what we thought is trying to do a multi-center study with end-of-life care assessments to try to find a way to do those. So then the secondary objectives then were, can we develop a framework to allow us to access these patients so that we can get advanced consent, and to learn about the experiences of family and friends and carers. And why do we want to do this? Well, we want to do it so that we can enable future research for patients who are dying, and also that we can learn about patients and families' experiences of hydration so that we can tailor their experience, tailor kind of communication and interventions for that purpose. So we came up with an advanced consent model, which I'll tell you about in the next slide. And also we adapted a existing questionnaire which had been developed as part of one of our consultants' master's project with help from patient and public feedback to develop a short questionnaire that we could give to relatives as part of the study to get their perceptions of what hydration is, the hopes and beliefs and attitudes associated with that. So the current law is that no individual can provide consent on behalf of another person. But we know that many patients want to be enrolled in end-of-life care research. So the challenge comes about how to access these patients and recruit them for research. So we have seen previous advanced consent models, so we tried to adapt this. So what we did was we developed a framework where we would look to recruit a patient for the study, and the consent form talked about how we were interested in working out what the quality of life and how symptoms were related to hydration in those patients as they were dying and approaching the end of their lives. And what we'd like to do is a baseline assessment, and then if people's conditions changed, we'd want to do another assessment. If they had lost capacity to provide consent, would they be happy at this point in time to provide consent for that? And if they were happy, then what we'd do is with their help, nominate somebody that's close to them, that knew their wishes and preferences, so we could talk about that, which would act as what's called a consultee. And then at the time where we needed to get assent from the consultee, would approach the consultee, say, this is a situation, your friend or family member has lost capacity. They previously stated that they want to take part in this research study. Is that okay to go on? And if they say yes, then we go ahead and do the assessment. If they say, actually, I would prefer you not to, then we wouldn't. So the consultee is not providing consent, they're providing assent for a previous decision that the patient has made. So we were very clear, and we discussed this with the patient public representatives, and they said, just be very clear. And we went that to ethics, and ethics were absolutely fine with it. We had no problems getting this through ethics. So this is what we did. So we, the process was that we'd get consent from the patient, and then we'd identify a consultee, which is often their next of kin. And to be honest, what happened initially was that we'd go off and try to find this person separately, but then we ended up doing all the assessments together with the person at the bedside. And we'd find out if there's a friend or next of kin available. If there wasn't a consultee available, so some people were on their own, we'd say to the patient, would you be happy for us to nominate a consultee that may be a healthcare professional? So if there's no consultee available, then we'd nominate like one of the nursing staff or somebody. If a consultee was available, then for this study, then what we do initially is to say, look, we've got two things we want to talk to you about. One is this hydration questionnaire that we want to get the experiences of patients and their families. Would you be happy to complete this? And there was a separate consent form for that. And regardless of the outcome of that, we then, if they said yes, we'll give them the questionnaire. If they say no, then we still ask them if they want to be a consultee. If they said yeah, they'd sign all the paperwork. We'd communicate that with the patient. We'd encourage them to have ongoing talks about it. If they said, I think it's a good idea, but I prefer not to do it, then we'd try to find an alternative person. And then we just keep on going around until we appoint somebody. If we couldn't find anybody, from the family that wants to do it, because sometimes people just didn't want to take that responsibility. They liked the idea of the research, but they didn't want to be put in that position. We'd then go back to the patient saying, are you happy for us to use a healthcare professional as your consultee? And in that situation, if that person had deteriorated, the healthcare professional would still probably double check with the family. So that was that. Now, but if we weren't getting anywhere, then there'd be no further participation. When the patient, patient's consented, we do the baseline assessment. So they've had capacity, all these patients have got capacity at this point. Then we'd wait and see, keep on doing the study. And if somebody's condition then deteriorated and it was felt they were approaching the last 7 days of life by MDT consensus or by the presence of an individualized care plan, whatever that looks like, then we would, we'd identify this person, go to see whether they have mental capacity, because if they still have capacity, then we'd ask them if we could do another assessment. If yes, we do the second assessment. If they say no, obviously we wouldn't do a second assessment. But if they don't have mental capacity, then we'd approach the consultee and say the consultee, say this person previously they want to be part of research. We've done the baseline assessment. They've now lost capacity. We want to do the second assessment, which is completely painless, take a few seconds. We've already agreed about it, had this discussion. Are you happy for us to do this? Okay. And if they're not happy, then we wouldn't do the assessment. Okay, so that was it's quite a complex process, but it did actually work really well. So the patients that we were recruiting were patients who had advanced cancer, and for this study, we were recruiting from two sites, Marie Curie Hospice and the Academic Palliative Care Unit, which is a 12-bedded palliative care ward in the Royal Liverpool Hospital. And we were doing assessment of hydration, symptoms, which we're using the Edmonton questions, but also 3 oral health questions, which we identified from our previous work to be associated with hydration. So those were dry mouth, thirst, and fatigue. And then physical signs, which has been shown in the literature to have some association with dehydration, and then a quality of life scale, which was 7 questions. So that was the baseline assessment. And then for patients who thought to be in the last 7 days of life, we would just do the one-off bioimpedance assessment, and we'd also have a proxy comfort score, which a healthcare professional would roughly judge their level of comfort, very subjective, just about pain, agitation, and respiratory tract secretions. Other measures, we're recording the mean morphine, equivalent morphine dose, and the anticholinergic burden scale. And part of the reason is so that we can compare this to things like cognition, fatigue, and oral mouth care. From our previous study, we recorded this information and found that there was no correlation between dry mouth and thirst with the anticholinergic burden from medications and the dose of morphine. So we're just repeating that in the background. Performance status, all fluid intake in the past 24 hours of the assessment, and obviously the hydration experience questionnaire that I mentioned before. The study is broken down into 2 phases. It's got a feasibility phase just to see how this works, where we're looking to recruit 30 patients. And then following that, the plan's then to go back to ethics to work out whether we need to make any changes based on the above protocol. So we were able to get just under £60,000 of funding from different funders, including the Academy of Medical Sciences, which we used to buy out time for one of our doctors in the hospice and our research assistant and a nurse who was doing research sessions. And we also had support from the NIHR nurses in the hospital. And there's a kit that we bought. So the current progress is that we've recruited all 30 patients from the feasibility. We did this in 3 months. So the overall recruitment rate is 60%. 30 out of 48 patients agreed to participate. And a lot of the feedback was this is the only study available for us to do in these areas, and they really wanted to do it. And 6 of those recruited went on to have a further assessment because they were dying. So we were able to recruit 20%. Part of the reason for the high numbers, 150 overall, that we're trying to recruit is because we're powered to get 35 patients who were in the last 7 days of life. So, you know, the fact that we've got 6 patients already, I'm really pleased with that. And 60% of caregivers have completed the questionnaire, so we have 18 questionnaires so far. So the proposed outcomes, we want to help develop a hydration assessment tool, which could be then used for intervention studies for hydration, if we have standardized outcomes. And we also want to help do further assessments in the dying phase, not just for this study, but for other work that can reference, you know, our methods. And we want to gain insight into experiences of families and carers. This is our study team, which I'm very grateful for. We were looking to do the study across 3 sites initially in Marie Curie West Midlands, but that's not been possible at the current time. But there are opportunities potentially to collaborate further and wider afield. So the next steps is that I've just submitted a grant to the Wellcome Trust for £97,000 to fund a researcher to do the next phase of the study. When we approached funders initially, many people said, the study's too ambitious, you won't be able to recruit, so you need to do a small-scale feasibility study first, which we've done. We've demonstrated that you can recruit from 2 sites for patients the last week of life. So the hope is to try to get, you know, funding now so that we can do the next bit of the study over a 2-year period. You know, I'm amazed, to be honest, that we managed to get, you know, the team worked incredibly hard because we had funding for 6 months, we had delays with ethics for 3 months. So the fact that we were able to recruit 30 patients in 3 months, it's just, for me, demonstrates that patients do want to be part of research. So for me, there's real opportunities for future collaboration in studies like this with hydration. You know, the bioimpedance, for me, is a way to help the evidence base, but not necessarily, but I'm not expecting people to be carrying around these bioimpedance machines. But what I'm trying to do is try to add to the evidence base to improve our knowledge of hydration. So there's future work that could be done in hydration studies, but also what you've seen is that bioimpedance is very good at prognosticating, and previous studies have just done prognostication studies for studies like COPD and cancer, but there's other areas which haven't been touched, like stroke and renal disease. So there's real opportunities to use this technology to try to improve our prognosticability. I've also got interest in technology projects, and there's a few ideas there about sensor-based technology, Internet of Things, connected home, virtual reality, telehealth. So all these technologies are coming, and there's a real opportunity there for future work and collaboration. So the future. So I've been appointed as a consultant in palliative medicine at the Royal Liverpool Hospital, which I'll be starting in October. I'll be working there 3 days a week clinically. I've also one of the inaugural NIHR research scholars for the Northwest Coast, and NIHR will pay for a day a week for me to do research for the next 2 years. And the aim is to help facilitate networks and collaboration across the whole of the Northwest. And then I'm also working a day a week in Marie Curie, just as the contact person to try to facilitate future research. So 3 days in the Royal, 1 day NHR, 1 day in the hospice. What could possibly go wrong? But my hope is that we can look to work together across the region, through the university, through the excellent hospitals in this region, and through excellent hospices like Trinity Hospice. I think there's a real opportunity here to all work together and collaboratively on projects that can really improve patient care. My last slide is the lighthouse. This is Whitby Lighthouse. My mother-in-law recently died, unfortunately. I have 3 children, and she died the day before our third child was born in February. It was about a year ago that she had the news about her recurrence, and I asked her, what do you really, what's most important to you? What would you like to do? She came up with a list of things, but one of the things that she really wanted to do was to go to Whitby Lighthouse. She talked about wanting to go to spend the night in the lighthouse. So I was like, we're going. And everybody was like, but there's a severe weather warning next week. I'm like, we need to go. Look, it's paid for, but the road's terrible. We're going. So it was one of the worst journeys that I've ever had. My heart was in my mouth because the visibility was so bad. We had to stop a few times. But when we got there, the storm cleared and I was able to take this photo. And it made me think that difficult roads often lead to beautiful destinations. That's the story that for my aunt, that's the story for Alison, my mother-in-law. And I believe that's a story for much research. So I'd say that I think keep going. And I think together we're stronger. So I think there's real opportunities to share each other's experiences. Just a note to thank all the patients that took part in the studies that I've done, to thank the research team that I've worked with, and to thank the funders. Thank you very much.
Really fascinating. So I think we've got some time for questions. So see if there are any online questions as well. But any questions from anyone in the room, first of all? Oh, hands straight up.
Thanks very much. That was really very interesting. I was just wondering if you used any sort of guidance for people about determining what this last 7 days might be, whether there's anything, whether you found that, I know you've only got small numbers at the moment, but whether people survive longer than that.
I think that's an excellent question. I think the challenge that we have is that I just physically haven't had a chance to look at the data yet, and I think so the way that we dealt with it is that we said MDT consensus. So we'd have the researcher going to the MDT, asking, do you think of any of these patients who've enrolled to the study? Do you think that they potentially might be in the last 7 days? So that's subjective. The other was the individualized care plan. I know previously studies like this may have, used kind of the LCP to kind of indicate those individuals. So, there's always going to be a bit of subjectivity about whether or not. So that's as close as we wanted to put it. We were thinking about additional variables like not able to eat and drink, but we generally thought, well, we'll go on MDT consensus and the presence of, this documented, this patient is in the last hours to days of life.
I just wanted to ask...
Oh, sorry.
Oh, right, okay. I just wanted to ask about the kind of the recruitment of patients and how it felt speaking to people about the end of their life and research in anticipation of that, and whether you encountered any difficulties with patients kind of psychologically or sensitively around this kind of recruitment.
I think that's a really important question, and we we were very clear with the patient and public engagement. We kind of asked about this, and they were saying, we think you should just be very open. So the language that we used initially was, we're interested in people who are very ill, who may not recover from their illness, and hydration is really important. And what we want to do is to look at a study where we assess this in people as their conditions change, as they may be approaching their life. So we very much talked about it like that. From the patients that we recruited, we didn't see, there was no reported evidence of any distress, because we had to have a whole section or ethics about how we would deal with that, and we didn't have to activate that protocol at all. We also kept a screening log, which again, because the data is with the research assistants in 2 different sites, I just physically haven't been able to look at this. So in terms of how many patients were screened and kind of filtered out, because there was the concern that might cause distress, I don't know. I think there's always a danger with this type of studies that you get gatekeeping. So patients who actually might want to participate in this study, you may not get the opportunity to see them, because the way that you see them is through the clinical teams. So a big job that we had to do initially was a lot of workshops and engagement with the staff, showing them the equipment, telling them about the previous study. We found that research seminars didn't work because the nurses couldn't go. So I'd go to the handover meetings and and just casually talk about when they were having their lunch breaks about the study and how important it was, and if they had any questions. So I think that's the concern that we had, because when we did the original study, it was really slow to recruit, and we recognized it wasn't because people didn't want to do it, it's just I couldn't get access to the patients. So from the patients that we approached, no evidence at all. For the 48 patients that we approached, nobody got upset. You saw that 60% of patients said yes. So 18 people actually said, no, this isn't for me. Just as you would expect for any type of study, but they didn't have any signs of distress. So I think it's important when, if it's felt very strongly that people will get distressed from talking about this, then I think that's fair enough, but it shouldn't be used as a barrier to get recruit patients. But I don't know yet because I haven't seen that data.
No, that's what. But did you use the words death and dying in the participant information sheet?
So we used the word dying a couple of times, and the patient and public representative told us to put it in. The ethics committee were a bit were a bit kind of concerned by it, and asked us to change some of the wording around, which was some of the things that they asked us to do I didn't quite understand. Dying is there because in some of the narrative we talk about as people approach the end of their life, it is a concern as people are dying. It's there, it's in the text, but it was the ethics committee that wanted to go softer, but it was our patients, our 2 patients that we saw in day therapy and our 2 patient representatives who were volunteers said, no, it's really important to talk about this. So it is there, but not as much. So we had a NIHR research nurse in the hospital, and we had and we bought time out from a doctor and a nurse who'd been seconded from another location to do the study in Marie Curie Hospice.
How were they prepared to do infections? What was their background?
So they didn't have experience in clinical research. So what we did, they did the GCP training. They'd had advanced communication skills training. They'd spent some days with the research team in the hospital, and they'd done a face-to-face module about getting consent and people who struggled to provide consent. So we tried to prepare them as much as possible. Yes, the background of those 2 individuals for palliative care. but the research nurse was a generic research nurse.
Could I ask if there's anybody online that would like to ask a question? Your microphones are switched on now. You are live.
Hello, this is Arun. I'm online over here. Can you hear me?
Can you hear Aaron? I can't hear. Sorry?
Hello.
No, sorry. I can hear you. Hi, Aaron. Sorry, we can't hear you in the room, but if you'd like to ask your question, I'll translate.
Yeah, so my question was that is there any standardization or calibration for the bioimpedance machines that were used in the study?
Are you asking what is the calibration used for these machines?
No, and the machines that he used in the study, are there any standardization or calibration that is to be fixed for those machines that have been used?
Is there any standardization or calibration?
Yes.
Yeah, so all the machines are calibrated to deliver a frequency of 50 hertz. There's different types of bioimpedance analyzers, and you have multiple frequency or single frequency. Multiple frequency research is quite complicated, so the analyzer that we've used is single frequency because it's easier to interpret. And you have a test circuit that you put in to make sure that you're getting the same readings. The readings give you three outcomes. One is resistance, which is the resistance of electrical current as it passes mainly through water. Then there's reactance, which is the resistance as it passes through cellular structures. And from those two readings, you can generate a third reading, which is called phase angle, which is a marker of overall health of a living system. So if you do a phase angle of a tree, you'll get something like 10. If it's a dead tree, you'll get 0. So as the phase angle falls, it works as a prognostic indicator. So each bioimpedance machine has a test, have been calibrated. There's not many companies that make them. And you have a test circuit that you put in to make sure that the resistance and the reactance that you're getting are within 1% of the reading. So they say that you do this every week. I had OCD, so I did it every day. And then, so even though there's different companies making the analyzers, they're standardized to the same frequencies, but you're then able to compare all the research, irrespective of the analyzer used, by doing the BIVA method, which we did. So, we can do our study using our analyzers from Italy. Somebody can do the analyzers from America. They've all been standardized the same, but we can still compare them with the same statistical trick that we did in this study. Is that okay?
Yeah, that was a lot of information. Thank you.
All right.
No, it'll cause feedback.
Can I ask so just imagining a patient who's got gross edema but actually is quite dehydrated, or a patient with a large volume of ascites, does it pick that up?
And that's an excellent question. Thank you for asking that. So the limitations of the bioimpedance method, as we talked about, normally what you want to do is I do an assessment on you, and then I'd look at I'd say, okay, I put in markers like kind of sex and height and things like that into the equation, and you'll be able to tell you where that fluid is. Is it in the intracellular space? Is it in the extracellular space? But the problem that we have is that it has certain assumptions. So those assumptions are things like, it expects you to have 4 limbs. It doesn't expect you to have a BMI under 16 or over something. So these equations are all geared for athletes. So with BIVA, the compromise is it gives you data that you can compare one person to another, but you then lose that accuracy of knowing where the fluid is. So one of the challenges that we have is I can say people are kind of less hydrated, but effectively what it's looking at is a total body water. I don't know where that fluid is. Single frequency analyzers provide you that information. The reason that some people are now moving towards the multiple frequency, so rather than using the one frequency, it's like everybody was at 50 hertz. You could do 20 frequencies, and the different frequencies mean that you can penetrate the muscle and the fluid more accurately, so I can work out exactly with the multiple frequency analyzers where that fluid is. So I received the Academy of Medical Sciences grant for this project, and from that I've used £8,000 to buy a multi-frequency analyzer, because one of the studies I'd like to do is a study looking at fluid shifts for patients who have got third space movement, ascites, lymphedema.
Huge thank you to everyone who's joined us online, and of course to Ami. Thank you very much. That was really interesting. Thank you.